So that's a great question. There is a lot of work being done in terms of biomarkers for different ADCs. We know that HER2 we used to treat only patients with truly HER2 positive, traditionally per IHC and FISH, but now we know that T-DXd has really been very effective in patients with tumors that have HER2 low expression or even ultra low expression. So I think for HER2, the main thing is that we need to learn how to measure it well and what's a reliable way to measuring it. In terms of Trop-2, it's been another one that has been studied. It's not commercially available, and it's really not needed because we know that patients that are treated with these Trop-2 targeted ADCs respond well irrespective of Trop-2 expression. There are, however, very many other ADCs that are being studied. HER3 targeting ADC is very interesting, B7-H4, B7-H3, so different targets, some immune-mediated, some more similar in the HER2 superfamily. And I think that's going to be very interesting and very important as we start using these agents in the early stage or as a one line of treatment in the metastatic disease to have other options. So I think many of those are coming down the line. But currently, we're not testing for them. We only have Trop-2 and HER2 targeted ADCs approved for breast cancer. Yes, so that's a very exciting area. Currently, we only have TDM1 approved in the adjuvant setting for patients with HER2 positive residual disease after neoadjuvant therapy per the CATHERINE trial. But we have several studies looking at ADCs in this space, and I anticipate that we will see some exciting results. So I will think about it in two ways. One will be in the neoadjuvant setting. Do we have patients with very low risk disease that perhaps we can give an ADC for a short period of time and then forego the chemotherapy, the traditional chemotherapy, as we're doing in the ATTEMPT 2.0 study with TDM1, for example? We could also consider perhaps escalation or tailoring the treatment a little bit for patients with receiving neoadjuvant therapy. So it could be done in different ways. For example, in the NeoStar study, they did sacituzumab govitecan with or without pembrolizumab. And then you can assess the response after 4 cycles and decide if you add some standard chemotherapy or if you go straight to surgery, or perhaps just combining chemotherapy with ADCs, as they are doing in Destiny Breast 11 that we're seeing presented in a few weeks in ESMO, that they did THP and T-DXd, for example, a combination. So there is a press release. We know that that was a positive study. We need to see the results, but it's perhaps a better way to achieve a PAT-CR in the neoadjuvant setting. And the other side is for patients with residual disease after neoadjuvant chemotherapy, particularly for HER2 positive and triple negative. We know that it is associated with poor outcomes. So can we optimize, especially in triple negative, for example, we're giving the Keynote 522 regimen that has 4 chemos and immunotherapy. So if they have residual disease, the standard currently is to give more standard chemo and immunotherapy. So I really think that there is a space there to give targeted chemotherapy with an ADC. And this is being studied in different settings. The ASPRA trial that we have at Dana-Farber is looking at the combination of immunotherapy with sacituzumab for patients with detectable ctDNA or circulating tumor DNA and residual disease, ASCENT-05 for Optimize, sacituzumab again. We have Destiny Breast 05 for HER2 positive residual disease, so it's similar concept to CATHERINE, for example. So we have different trials ongoing, and that I think it's going to likely bring these novel ADCs to the neoadjuvant and adjuvant settings. So this is a very important question. The management of toxicities of ADCs is an ongoing and a learning curve for all of us as these agents are getting into the clinic. I think specifically for interstitial lung disease or ILD, close monitoring for patients receiving trastuzumab deruxtecan every 6 to 12 weeks with CT scans and very low threshold to scan patients if they report any respiratory symptoms. You have to stop the treatment right away and start steroids for several weeks with a very slow taper. I think patient education and provider education, we're talking about curative settings. So I think that sometimes the threshold and what we're willing to take in terms of toxicities is different. So this will be something to consider as well. For other side effects from ADCs, I think we have with some alopecia that we need to counsel the patients about. We have GI toxicity that, especially with sacituzumab, aggressive nausea regimens are recommended. Cytopenias that sacituzumab, again, with some people use growth factors, for example. So bringing all of this into the clinical practice and considering that if this is in patients in the adjuvant setting after they had a lot of treatment, it may be different. The way they respond, they might be more prone to some of the toxicities or perhaps less open to some of this treatment because it will be more intense likely than what we're doing now. So we really need to show that this improves outcomes for patients. But if there is a big difference for patients with residual disease, I think being aggressive with symptom management and patient education is very important. So HER2 testing, it's a very challenging topic because the tests were designed to detect HER2 positive or HER2 negative, and now we have all this range. So there is a lot of work from different labs, from Dave Rim, for example, from Yale, looking at quantitative assays for HER2. And we really need to see how to bring those into the clinical practice so we can identify the patients that need or that can benefit from HER2-directed ADCs. And on the other side, we have seen that the majority of patients benefit from T-DXd, even with HER2-ultralow. So I think just specifically differentiating between HER2 0 and 1 and null versus ultra-low will be very important, and educating pathologists to incorporate this, and so all patients have access to these drugs. So that's a great question. We have seen studies for metastatic triple negative, PD-L1 positive. We saw a CENTO-4 presented in ASCO this year that showed a benefit. And I think this will likely become standard of care in the near future. I think identifying biomarkers in the metastatic setting has been somewhat less challenging with PD-L1, which has shown to be an excellent biomarker for metastatic triple negative disease. We still need biomarkers in the early stage disease to identify these patients. Even before we get to the ADCs for chemo and immunotherapy, for Keynote, we really don't have a good biomarker, and we are giving a lot of treatment and a lot of potential toxicity to patients that might or might not benefit. So I think a lot more work is needed to identify biomarkers and to ensure that patients are getting the treatment they will benefit from, prevent toxicities. And I think as we start talking about immunotherapy and ADC, we also have to think about financial toxicity.